A very good morning to all who have joined today's webinar on the topic Genicular Artery Embolization, Regain Your Pain-Free Knee Without Surgery. Presented by MIOT International under the Hindus Wellness Series, today's session, I can vouch, brings in some good news for all those suffering from knee osteoarthritis and are reluctant to undergo the traditional procedure of total knee replacement surgery in order to relieve themselves of pain. There is now an innovative, minimally invasive, non-surgical, and a novel intervention available for patients with symptomatic knee pain that occurs due to the gradual wear and tear of the cushioning tissue between bones in the knee joint called the cartilage. As a result of this, people feel stiffness and swelling in their knees. They are unable to walk or climb stairs, and it hinders their mobility and quality of life. Experts at the MIOT Hospital are successfully doing the genicular artery embolization on patients and relieving them of their knee pain without surgery. And we have with us one such expert today, Dr. Karthikeyan Damodharan, Director, Vascular and Interventional Radiology, MIOT Hospital, Chennai, to talk about it in detail. Welcome, Dr. Karthikeyan, and we are eagerly waiting to hear you speak on this relatively new procedure called genicular artery embolization, which you said has been introduced by a Japanese radiologist about a decade ago and practiced in India for the past 3 or 4 years. Welcome, Doctor.
Thank you, ma'am. Thank you for the kind introduction. Thanks, everyone, for joining us on this webinar about a new treatment for knee pain due to osteoarthritis. I am Dr. Karthikeyan, and I work as the Director of Vascular and Interventional Radiology at MIOT Hospital. And at MIOT, we take great pride in staying at the cutting edge of medical technology when it comes to the new procedures or new equipment, which will help provide the best care for patients. In keeping with this trend, we have introduced this new revolutionary painless pinhole treatment for patients suffering from knee pain, and this procedure is called genicular artery embolization. Before we talk about this procedure, some of you in this audience would be wondering what exactly is interventional radiology and what does an interventional radiologist do? So I'll give a brief introduction about what exactly this specialty entails, and then we'll move on to our presentation. So interventional radiology is a highly subspecialized field of medicine where we use imaging guidance to treat many medical conditions in various parts of the body from head to foot without opening the body, just through a pinhole access. And in case you're wondering how it's possible, it is possible. I'll explain why. We all have had scans like X-rays or CT or ultrasound scan, or know of people who have had scans where the radiologist, who's a specialist doctor, who looks at these scans and exactly tells you what and where is the problem in your body. Now, interventional radiologists take this one step further. We actually use this scanning technique to see inside your body and actually treat the problem in your body without opening you up, without doing surgery. And that's the field of interventional radiology. Now, how is this possible? Now, if you focus on the image I put in here, now you can see the body's network of blood vessels, which looks like highways in the country. So if you can see, if I can access one blood vessel either in the groin, which we normally do, or in the wrist, we can reach the blood vessels to the heart, to the head, or down to the feet, and thereby we're able to deliver treatments. And we do this through tiny tubes called catheters, and various equipments we push through these catheters to deliver these treatments. One other technique we use is, again, as we scan the body, we can see exactly where the organ we need to treat is, and we can directly introduce a needle through the skin into the body, again through a pinhole access, and deliver the treatments. So what is the advantage of this? Because we're doing it through a tiny pinhole, which you're talking about 2mm hole in your body to treat these conditions, these procedures can be done under local anesthesia without the need for general anesthesia, without the need for a major cut opening of your body that shows no major scar. And because it's done through a tiny pinhole access, it's a very safe procedures. There's very little risk of having complications. And what's the best thing? Patients can go home within a couple of days of the procedure, be it even a major procedure like an aortic surgery, without having to stay in hospital for long. And when they go home, they don't physically go home. Functionally as well, they're fully back to the normal activity. And that's the biggest advantage of interventional radiology. And as I said, we can provide treatments for several conditions from the head to toe using this technique. And to talk about all these treatments would be a separate lecture. I would request people who are interested to go to our MIOT website, and you can see the list of procedures we perform using this technique. And I just want to briefly highlight some of the few procedures we do just to give an introduction. So the first one I'm going to talk about is angioplasty. This is a technique which simply means to open up blocked blood vessels. Many people have heard the term angioplasty or stenting when it comes to the heart. When you know that when a patient has a blocked blood vessel in the heart, they develop chest pain or they can have a heart attack. Similar thing can happen to the patients in different parts of the body. And that's why we do this procedure called angioplasty. And as this picture shows, you can see when there's a buildup of fatty deposits inside the lining of your blood vessels, there is narrowing of the blood vessels, so the blood flow to your organ gets reduced. And because of this, they can have various problems. And so we introduce a fine catheter, which has a balloon loaded on it. And then when we inflate the balloon, it tends to displace this fatty plaque away from the center of the lumen and widens the blood vessel up. And then we remove this catheter. And then, as you can see, the blood vessel is much more wider now, and the blood flow can reach the organ, and the problem gets resolved. For example, one of the commonest parts of the body where we do angioplasty is, it's a very common condition a lot of people know about, but they do not know that angioplasty works for this condition. It's called diabetic foot. A lot of diabetes people have developed wounds on the leg which do not heal for a long time, or they develop skin discoloration, what we call as gangrene in the foot. And unfortunately, this problem is due to the blocked blood vessels in the leg arteries. And usually the treatment is being done as medical treatment, or they simply end up losing the leg, which is a very, very radical, cruel treatment, I would say, for this condition. Now, in interventional radiology, I've shown you pictures of a blood vessel in the thigh of a patient who had this procedure done. The black thing you can see is the blood vessel, which has got many branches. As you can follow the blood vessel, there is a gap in the blood vessel here where there is no flow coming through. And somehow blood is trying to find its way through other pathways to reach the vessel below. So because of this, he was having severe pain, and he had a gangrene in the tip of his big toe, which means there's a blackish discoloration and the toe is starting to die. And he was in his 80s, and he was told that he has to lose his leg below the knee because this would not heal for him. And there's a risk of it progressing higher up and causing major problems. So he came to us at MIOT Hospital. As you can see in the picture on the right, we have opened up the blood vessel by doing a procedure called angioplasty, where we stretch the blocked blood vessel and open it up. And you can see a straight line flow in the blood vessel going down to the leg. And I've just shown you pictures of his foot. This is the big toe gangrene, or the discoloration of his toe, which he presented with at the time of presentation. And you can see 6 months later, his toe had completely healed, and he was very, very delighted that he could keep his leg without having to lose his leg. And 3 years on, he's still doing well, and he comes to my clinic to see him. So this is the advantage of doing a procedure like this, where this procedure was done under local anesthesia, and the patient went home 2 days after the procedure. But of course, it took time to heal this wound, but he was out of danger of losing his leg. Another procedure we do is called embolization, which is one of the types of procedure we're going to talk today. This simply means we block unwanted blood vessels which are causing the problem. Where does it help? One of the common treatments we do is for fibroids. When patients have fibroids in the uterus, they suffer from heavy or very painful periods, and the conventional treatment that is offered to them either is surgical treatment, where they remove the entire uterus, or they remove just the fibroid in the uterus. But there are many women who do not want to undergo major surgery on the uterus or lose the uterus, and they suffer from this pain and heavy periods for a long time. As you can see in the diagrammatic picture here, same thing, we introduce a tiny catheter to the blood vessel in the groin, and this is directed into the blood vessel supplying the uterus, and then we inject tiny particles to block the blood flow. On the right is the actual image when it happens during the procedure. That white gray thing is the tube which comes into the blood vessel of the uterus, and we inject dye called contrast, and it shows up the blood vessels which we need to treat, and then we block them. So as an example here, this is a young woman in her 40s who was working as a teacher, who was suffering from heavy periods which would last 15 days. and she would find it great difficulty to go to work because of this issue, and she was losing her self-confidence. But one thing she was sure is she didn't want to undergo surgery because her gynecologist told her hysterectomy or uterus removal is the only choice for her because of the heavy period she's been having. But she, having seen her mother undergo hysterectomy at a young age and develop a lot of medical problems after that over the long term, she was very strong that she didn't want this treatment. And she came to a camp which we ran for fibroids at MIOT, and she had it treated by this procedure. This red circle highlights the fibroid, which is sitting inside the uterus, shown here. And after the treatment, the fibroid dies, and usually it shrinks down to 50 to 30% of its original size. But in her case, the fibroid completely disappeared. As you can see, her uterus, 6 months after treatment, there's no fibroid in her uterus, and she was very delighted. The last one I'm going to tell about is a procedure called ablation. This is a procedure we don't go through the blood vessels. We introduce a needle directly through the skin into the organ we need to treat. Of course, under ultrasound or CT guidance, we can see the needle under real time and deliver treatments. So in this treatment, the special needles are used to heat up the tissue we need to kill, and we remove the lumps without opening them up. So here is a lady who had a huge thyroid swelling called a goiter, and she's been having this for several years. Again, she was not keen to undergo surgery. She was told she needs a open surgery called thyroidectomy, where they remove the entire thyroid gland. And again, she was not keen to undergo this treatment. And when we launched thyroid radiofrequency ablation at MIOT last year, she heard about this and she came to us for treatment. And then she underwent this treatment where, as you can see in the pictorial here, we introduce a needle into the thyroid gland, which sits in the midline of the leg. And we use ultrasound scan to see the needle, and we do this procedure under local anesthesia. The patient is very much awake. We introduce needle because we use local anesthesia. They don't feel the pain. This procedure probably takes half an hour to do. And after that, they go home the very next day. Compared to a major thyroid surgery, they'll be in hospital for at least a week, and they nearly end up with a very big scar in the neck. So these are the results of her procedure. 6 months later, the gland has completely shrunk in size. And you can see that the nodule is still there, but compared to what it was, it's nothing for her. It's almost 30% of what it was before. And she's very happy because she was losing her self-confidence, because anytime she goes out, people ask her about her thyroid swelling and why don't she do something about it. But because she didn't want to do surgery and she was pushing it away from, and once she knew that there is an option called thyroid ablation, she was very happy that she could have it done. So with this introduction, we will move on to our actual topic about knee pain due to osteoarthritis. Now, let's talk a little bit about why this osteoarthritis happens. Now, osteoarthritis is a condition where naturally, as we age, all parts of the body gets wear and tear. There is natural wear and tear happening in your knee joint as well. What happens is, as you can see the x-rays here, the left one shows a normal knee joint where you have the thigh bone joining with the shin bone or the leg bone, and between there's a black space you can see, which is actually filled by a cushioning material called cartilage, which is like a washer which sits between two hard pieces. So when the body is moving and the joint is moving, this provides makes the movement very smooth without any friction between the bones, and it makes it easier for us to move the joint. It's called cartilage. In osteoarthritis, as people get older, this cartilage or this washer gets worn out, gets thinned out, because over time we use it for walking, and this is one of the most commonly used joints in our body because this is what makes us walk and move around. So this is very crucial. So when this gets worn out, the bones start rubbing with each other. As you can see in the picture on the right, you can see there is no space between the two bones on the inner aspect of the joint. On the outer aspect, there is some joint space still left. So what happens is the cartilage, from its original thickness, it starts slowly thinning down and eventually at one point gets completely worn out. And this is when the patients start developing severe pain. When the early stages, they do have pain, but the pain is only when they do a lot of exertion. When they do the normal activity, they don't get pain. But as it gets severe, slowly, gradually, the pain gets worse and worse. And then at one point, they found it excruciatingly painful even to walk from the bed to the toilet. That is a very, very disabling condition. You can actually call it a disability because they're not able to do the normal mobility. They can't move around, and suddenly they are dependent on somebody else or some other device to help them move from one place to another, even within their own house. And that is a very difficult condition to have, and you have to live with it the rest of your life unless you have a treatment done. Now, this condition, unfortunately, is very, very common. This is the most common form of arthritis affecting millions and millions of people worldwide. And statistics show that internationally, nearly 1 in 10 above the age of 50 years have this problem. In India, the data shows it's even higher percentage. Actually, they say it's more than nearly 1 in 5 above the age of 50 have it. Unfortunately, with the lack of physical activity and the lifestyle we have nowadays, with the sedentary lifestyle and the obesity pandemic increasing, we see patients in their 40s. The last 2 patients I treated in the last 2 days were 45-year-old females who had advanced disease where they can't walk anymore. They are not able to stand and do their work in the house, and they're struggling with pain. And they need some form of pain relief, and we'll talk about the treatment options here. So the symptoms they generally present with is pain. That's the earliest thing that starts. Over time, they develop stiffness in the joint. When they wake up in the morning, they find the joint is very stiff to straighten the knee joint. It takes a bit of time before they start moving around. And then, obviously, if they do too much exertion, they get swelling of the joint as well. So what are the risk factors for developing this condition? One thing, as we talk, it's a natural wear and tear which happens with age. So that is something which can't change. Somehow, for some reason, women get it more than men. I guess it's more due to their perimenopausal osteoporosis or bone loss, which happens around the menopause, which weakens the bones and also contributes to this problem. And now studies have shown that if your parents have this condition or your immediate relatives have it, you are likely to develop this condition because they think that genetic factors are also involved. But this is the latest evidence they have. But the more important thing is on the right side, which we're talking about modifiable factors. And the only thing I wanted to focus on is obesity. Now, India, as it's becoming a developing economy or a developing economy or even progressing economically, we are inheriting the problems which happened in the Western world, which is obesity. The alarming rate of obesity in India is increasing at a heavier rate. And because of this, it leads to a vicious cycle. Patients are obese, they develop knee pain, and they can't move. Of course, as I said, exercise helps to lose weight, but now they can't exercise. Now they're caught in a situation, the knee pain restricts their mobility, they can't do exercise, and they're getting more obese. So this is one factor which we can work on to reduce weight, which will help prevent the development of osteoarthritis in people in their 40s so that they can avoid this condition if they can. So now we will go into a bit of detail about what exactly causes this pain in osteoarthritis. Now we briefly talked about it, saying that there is a loss of this cartilage or the cushioning material between the bones. And I have a short animation to show you, which explains this in a pictorial fashion. So this is a picture of the knee joint, as you can see. And there is a thin lining inside the joint called a synovial membrane. And this is a lining inside the joint which secretes fluid, which also helps to keep the joint lubricated. And the cartilage is this light gray bit of tissue here between the two bones. And as you can see in this picture, they've already shown that the cartilage is getting a bit worn out. There are cracks in the cartilage. This is what happens. There's a tear in the cartilage, and this starts exposing the bone to the bone. So let's look at the animation. So as we talked about, that's a synovial lining of the joint, which is a very thin membrane. You can watch this membrane and what happens to this as we go along. Once there is cartilage breakdown, there's rubbing of the bones, and this time inflammation happens. Inflammation is a situation where the body does to alert us that there is something going wrong in the body. So it's a way of alerting us, signaling to us there is something wrong with your knee joint. So when inflammation happens, there is increase in blood flow happening to that area, and this growth of new nerve fibers, and also the synovial membrane, as you can see, is now become very thick. And they have all these new nerve fibers and new blood vessels. Now, we all know that nerve fibers are the fibers which conduct pain, and that's what signals to our brain that we have pain. So when they have new nerve fibers and more nerve fibers, they have more pain. Even when they just slightly move the joint, they feel exquisite pain. Normally, we move the joint, we don't feel pain, but we don't realize that patients with osteoarthritis, they find even the slightest movement causing severe pain, and that's because of these new nerve fibers caused by the inflammation in the joint. So when this happens, they can get severe pain, and it gets very severe. Even, as I said, even movement becomes a problem. So this picture depicts how in a patient with osteoarthritis, the cartilage gets damaged, it causes inflammation, and because of inflammation, the synovial membrane, which lubricates the joint, gets very thick, and lots of blood vessels and nerve fibers form there. which causes the pain. Now, what are the treatment options available? Now, this is a slow process as it's a wear and tear. It starts in the 40s when it's very early on, when patients feel that, occasionally they go for a run, they start feeling pain, or they walked a lot, they feel pain. But otherwise, their normal activities, they're doing fine. So when it's very early on, patients try using, the normal balms, pain balms, ointments, or Ayurvedic oils to apply to the knee joint, massage them to help relieve the pain. When the pain gets a bit more severe, they start going to the doctor and they get some painkillers to take. And these are technically called non-steroidal anti-inflammatory drugs. So basically, these are drugs which subside the inflammation in the joint and help relieve the pain. So what we know from that is inflammation causes pain. Anti-inflammatory subsides the pain because it subsides the inflammation. But these painkillers help relieve the pain, but they've got a lot of side effects. If one patient takes a lot of painkillers, they can develop permanent damage to their kidney and liver. And we also know that it causes irritation of the stomach lining, and they can develop ulcers in the stomach. So again, it's not a perfect solution, but of course it has its role in the treatment when they have acute pain to use that. Next thing is a bit more invasive when the doctor gives them an injection directly into the joint using a needle, and they use a lot of stuff. The commonest thing that is being given is steroids. Steroids are again anti-inflammatory medications. They subside the inflammation in the joint, but this injection taken very frequently does the opposite of healing the knee joint. Actually, it worsens the process of cartilage damage, and the cartilage gets wounded even faster if you get repeated steroid injections in your joint. So at MIOT, which is one of the highly specialized centers for orthopedics, we do see a lot of patients with complex problems referred from everywhere else in the country. We do not recommend steroid injections because actually it's detrimental to the patient in the long term. Another injection they use is called stem cells, or PRP, which is a new thing, which is actually a specialized component of your blood, which is taken out from your body and injected in your knee joint. Again, the evidence for this is very mixed in the medical literature. There is no concrete evidence to say that these things really make things better, because the PRP actually helps to regenerate the joint tissue. That's what the doctor tells you. Yes, it is useful in patients who are young, like athletes who have damage to the knee joint, like a ligament tear, where their regenerative capacity is very good. When you inject this PRP, it helps the regenerative process, fastens it, and heals the joint. But when you're at old age, you're degenerating and your regenerative process is not very great, doing these injections are of questionable benefit. And they do all have the side effects. The third and fourth thing are really useful, which is physical exercise, targeted physiotherapy exercises to strengthen the muscles around the knee joint, which helps to slower the process of degeneration, actually makes the knee joint better. But again, when they're in a lot of pain, you cannot do exercises. You need to have some treatment to subside the pain, and then focus on doing exercises, physiotherapy exercises to strengthen your muscles around the joint, to support the joint better, so you can prevent the progression of the osteoarthritis. And the last thing we already mentioned about weight reduction is a very, very important factor, which is one of the easiest thing, or easiest said than done, but the most important thing that we can do to prevent progression of osteoarthritis, because when we stand up, all the weight of our body is borne on these two knee joints. So if you're overweight or obese, the joint has to take this toll, and the cartilage gets worn out very faster. So if you have early osteoarthritis, you should start reducing your weight early on to prevent the progression of the disease. When it comes to the last stage, when it's very severe, when a patient can't simply move around, knee replacement surgery is the only treatment that can cure this condition. But unfortunately, not all people are eligible or keen to have knee replacement, which is a major surgery, and we will talk about it why. And so where does my treatment, you're wondering that I talked about a treatment called Genicular Artery Embolization, and I haven't mentioned this in the treatment options. Now, this treatment can fit in all subsets of patients from mild to severe osteoarthritis, but we will talk in detail where they fit in. So this picture on the right shows the artificial knee which has been placed in a patient, where they replace the ends of the bones which forms a joint, and they put a new articular cartilage or a cushioning material in between. But nature does the better job than us. Even with the newer scientific advancements, the artificial knee joints can last at best for 15 to 20 years, and after that, they get worn out. So again, if you have a knee replacement very early on, then you're looking at having another replacement, a revision knee replacement later on in your life, which is a very, very much complex procedure, and the chances of success become lesser. So let's look up which group of patients will benefit from this genicular artery embolization. Basically, this procedure helps to provide sustained pain relief without taking medications for these patients. So even if the patient has got mild OA, when they see the doctor will tell them, I've seen your X-ray and you have very mild cartilage loss. You are not ready for having a knee replacement. But the patient says, I have very severe pain. I can't tolerate the pain. These patients are ideal for having this procedure because they are not yet medically ready for a knee replacement. The doctor says so, which is right. But at the same time, they have pain, which needs to be sorted because they can't carry on with the normal activities. If they're in the 40s, they have young children, they have job, they have everything to take care of, and they can't simply live with this pain. So doing this procedure helps them relieve the pain and provides sustained pain relief without taking medicines for at least 2 to 3 years. So they can delay the process of having a knee joint replacement when it comes to it. Second group of patients, again, is patients who develop advanced disease in their 40s. We do see patients who have very bad osteoarthritis, the joint is completely worn out, and they're only in the early 40s. Again, the doctor will say, you're too young to have a knee replacement because if we do it now, we can't do a revision replacement again in your 60s, which is, again, a major surgery. So at our hospital, if patients are very young and they have this sort of problem, they refer it to us to do this procedure so they can buy time. We do this procedure, they get pain relief for 2 to 3 years. And if they're ready at that stage, the doctor will go and operate. Or if he says that you can push it a bit longer, then we can repeat the treatment again, the same treatment, to again buy another 3-4 years of pain relief. Third group is the group of patients who are old. They have multiple medical problems. They need a knee replacement, but they are not fit for having surgery because of their medical conditions or blood thinners they take, or they are high risk for having general anesthesia. And there is another group of patients who, again, need a replacement, but they are not simply keen to have open surgery. Maybe it's fear of surgery, or they do not want to have a surgery at all. So again, this group of patients, we can do this procedure to provide pain relief. Again, as I already said, this procedure only provides sustained pain relief by reducing the inflammation of the joint. It's not going to make the joint back to normal. So knee replacement is the definitive treatment available for this condition, but we can buy time instead of using medicines or injections in the knee joint, which have undesirable side effects. How does this procedure work? So in this procedure, we target the increased blood flow to the inflamed lining of the knee joint. And once we do that, we reduce the blood flow to this inflamed thickened synovium. Because of this, the inflammation comes down, and it also blocks this newly formed nerve fibers, which are transmitting the pain signal to the brain. And because of this, the pain subsides, and the patient gets a sustained pain relief. Because we block the blood vessels there, so the inflammation subsides, and because it's permanently blocked, it takes a bit of time. That's why we get 2 to 3 years of pain relief for these patients, because we are blocking the inflammation for 2 to 3 years. But because the underlying problem, which is their worn out cartilage and the rubbing of bones, is still there, the pain will eventually come back, because the body, as I told you, inflammation and pain is the only way of the body alerting to you that you have a problem in there. But unfortunately, patients can't live with this pain forever because they need to have some form of treatment so they can move around. So this treatment can provide relief for 2 to 3 years for pain relief, but doesn't cure the problem. Actually, there is no cure for osteoarthritis because it's an aging process. Nobody's reversed the aging process yet. So there is no cure for this condition. The only definitive treatment is knee replacement. But as we said, and as we discussed, not everybody is suitable for knee replacement. So how is this procedure performed? This procedure is performed in the angiography suite. And this is a picture of our highly advanced angiography suite, which is a biplane cath lab we have in MIOT Hospital. And this is one of the first installations of this very advanced angio suites in the country, which provides exquisite detailed imaging for us to do these complex procedures with much ease and delivers like safe treatment without much radiation as well. So I have a video pictorial to show you how this procedure is done. So patient will be lying on the X-ray table, and we give a small injection in the thigh on the side where the patient has pain to numb the area, and patient will be awake. And after that, we make a tiny 2 millimeter nick in the skin, small hole in the skin. We introduce this catheter, which is the yellow tube shown in this picture, and we gradually guide it under X-ray guidance close to the blood vessels supplying the knee joint. Once we are there, we inject this X-ray contrast liquid, which shows up on X-rays, and you can identify this newly formed abnormal blood vessels. And once we identify these blood vessels, we inject tiny particles. They are highly inert, medically grade plastic. We inject these tiny beads to block these blood vessels permanently. Please note that we don't block the normal blood vessels. We only block these abnormally newly formed blood vessels. So the normal blood supply to the knee joint is maintained, and it doesn't affect the normal blood flow to the knee joint. It only blocks this abnormal ones. Once it's blocked, it reduces inflammation because the block reduces the thickening of the inflammation and the pain gets better. Once it's done, we remove the catheters, patient takes rest for 4 hours, and after this, they can walk around and do their things. The pain relief usually takes 2 to 3 days for them to see the improvement in the pain, but they can walk around immediately after the procedure, not like having a major surgery where they're bedridden for 3-4 days after the procedure. So there are some patients who are not eligible to have this procedure, even though this is a minimally invasive procedure where we just do an injection in the groin. There are some patients who can't have it done. Who are they? There are patients, as we mentioned earlier, who have blocks in the blood vessel in the thigh. So we cannot actually reach the blood vessel to the knee joint because there is a block in the blood vessel on the way to the blood vessel to the knee joint. So these people cannot have this treatment. Now, there's a second group of patients who have other forms of arthritis, like rheumatoid arthritis, lupus arthritis. There are a lot of autoimmune arthritis where your own body attacks, your own body's defense system attacks your joints and causes damage to the joints. If that is a form of arthritis they have, they are generally not suitable for this treatment because the current evidence for this treatment is only for this naturally happening osteoarthritis of the joint. But having said that, there are some people with rheumatoid arthritis in the hands, but they have osteoarthritis or natural wear and tear in the knee joints. Those patients would be suitable for this treatment. So we have to do this treatment or provide this treatment to patients on a case-by-case basis after evaluating them. The fact that they have rheumatoid arthritis doesn't mean they are not eligible for treatment. If their knee joint is due to osteoarthritis, they can have this treatment. So we have to look at that. And there's a small subset of patients, some of them who are allergic to this X-ray contrast liquid, which we inject into the body, because this is very crucial. We inject this liquid, and that's how we identify this abnormal blood vessels. So if we can't give this liquid into them because they can have reaction to it, then we can't do this treatment for them. So why choose this procedure? Now, as we already discussed, it's a minimally invasive pinhole procedure, which all it involves is an injection, a small injection in your groin to do this treatment. And the recovery period is the fastest. As you can see, the 4 hours or 6 hours after the procedure, patient can be on their feet. And it's a recovery period is very short. Patient goes home the next day. Actually, in abroad, this procedure is done as a day case where the patients are discharged the same day. But in India, patients tend to, especially the older people, they want to take a rest a bit and then make sure they're all okay before they go home. And the healthcare cost in India is not very high, so the patients don't mind staying for a day extra, whereas in abroad, the hospital stay may be as costly as the procedure itself. So they rather prefer to go home. So in Indian setting, we keep them in for a day, especially they're old people with multiple medical problems. We keep them in for a day just for observation. But as I said, even in the hospital, after 4 hours of the procedure, they can sit up and do their walk around, and they can even walk to the washroom. And obviously, there is no need for general anesthesia. There is no major scar on your knee joint, and patients can go back to their normal life within 3 to 4 days of the procedure. And this procedure is very effective because we only target the inflamed synovium of the knee joint, and we don't affect the rest of the body. Like if you take an anti-inflammatory medicine, there is side effects on your kidney, your liver, or your stomach. But this one is only very specifically targeted on your synovium knee joint, and we permanently blocking this abnormal blood vessels. So the relief lasts for much longer, like 2 to 3 years. You take a pain medicine, you get pain relief for, say, 6 hours. You take an injection into your knee joint, like a steroid injection, which is not recommended. They may have pain relief for 2-3 weeks or a month at last. But these provide relief for 2 to 3 years, which is very long time considering the amount of pain and amount of restriction of activity this condition makes the patient do. And of course, once you do this treatment, it significantly improves their patient's mobility and quality of life because they're able to do their normal activity and there is no restriction on their lifestyle. And this treatment now provides an alternative treatment option, a very effective treatment option for patients who have not responded to conservative therapy or they're not suitable for knee replacement. I want to show you some cases of patients we had this procedure done at MIOT. The first patient is a very young lady. She's only 40. She had injury to a knee joint in a road traffic accident around 9-10 years ago. And then since then, she had an operation in the knee joint. But because your balance of your knee joint gets disturbed when you have a surgery done and you have an injury to the knee joint, she developed osteoarthritis very early. By now, she is wheelchair bound. When she came to us, she was on the wheelchair for the last 5 years. She has not been able to walk. She needs help to go to the toilet. Somebody has to push her wheelchair, and then she steps onto the toilet. So imagine her life in her 40s. She has a young kid who needs special assistance, and her husband is the only person taking care of her and her kid. She actually came to us asking for a knee replacement because she said, I cannot be like this. But our doctors evaluated her. We knew her condition was quite bad because she needs to move around, but we still told her that if she has a knee replacement now, she will be looking at having another one when she's 60 or even 55, which will be a major operation to do. So we decided to do this procedure. So we discussed with the orthopedic surgeon and we decided to do this procedure to help her relieve her pain. And the procedure was done. And these are some pictures from the procedure itself. The red circle shows the abnormal blood vessels, which look like thin strands of hair and some cloudy shadowing over there. These are the abnormal blood vessels. And once we do the treatment, you can see the picture on the right side where you can see the normal blood vessel. You can see, but you don't see just thin strands of abnormal blood vessels. This is done on the outer aspect of the knee joint. And the lower pictures show the similar procedure done on the inner aspect of a knee joint. Again, you can see the red circle showing you the thin strands of blood vessels, which are the abnormal ones, which are showing up there, and some hazy shadowing here as well. Again, we inject these particles, and you can see that hazy shadowing, all these thin strands have disappeared. And she had treatment. Within 3-4 days of treatment, her pain score, which was 10 on 10, which is the maximum pain she could experience for her when she walks, and that was 10 on 10, came down to 2 out of 10 within a week of the procedure. And then after the procedure, we advised her to undergo targeted physiotherapy at our rehabilitation center at MIOT because she has not been walking for 5 years. All her muscles in a knee joint had got weak. And even walking for anybody who's not been walking for 5 years would be a difficult task. So she was given targeted physiotherapy, and now she's able to walk independently and she's able to take care of her child. And she's very happy that she got her life back after this procedure. The next patient is at the other extreme. This is an 81-year-old lady with severe knee pain. Again, she's wheelchair bound. She has multiple medical problems, and she was considered unfit for having surgery because she's very, very high risk due to all her medical problems. And she used to wake up at night from sleep with pain. And she used to cry at night because the pain in the knee was so bad, it would wake her up and she started crying. And again, for her, because she takes painkillers, but again, she cannot take too strong painkillers. It affects her stomach. So she was advised to go genicular artery embolization. Again, we have pictures of her intraprocedural angiogram pictures. Again, you will be able to identify these thin strands of hair-like blood vessels seeing there. These are abnormal blood vessels highlighted here. And you can see on this picture here, those blood vessels are not seen. And this is on the outer side of a knee joint. And then again, we repeat the same thing on the inner side of a knee joint. Again, I'm sure you'll be all able to identify this abnormal blood vessels by now. You can see all these thin strands and this gray cloudy shadowing here. And on the last picture, those don't show up. So once she had the treatment done, again, within a week, her pain subsided. She was not waking up at night with pain. She still has pain when she walks because her knee joint is quite badly damaged, as I said, and she walks with a limp, yes, but at least now she's able to walk. She's very happy that at least she's now able to walk and she can sleep through the night without pain. So that's the advantage of this procedure. And we are at MIOT running a special camp for specifically targeted at people who have severe knee pain due to osteoarthritis, but not considering surgery. We are offering a special camp, which is going to run from the 1st to the 6th of July. And we are offering consultation for these patients and an X-ray at a very discounted price so that they can come and get evaluated to see whether they will benefit from this treatment. So I do request viewers as well as your near and dear ones who are suffering from this pain to avail this opportunity to come and get evaluated to see whether they will be able to get relief from the knee pain with this procedure. And that's the end of my presentation. I again thank each one of you for joining us for this session and patiently listening to my lecture about this procedure. So in summary, at MIOT, now we offer one more very effective, proven treatment for severe knee pain due to osteoarthritis, be it early osteoarthritis or severe osteoarthritis. For whatever reason, you can get pain relief without having to take medications or dangerous injections in your knee joint. Thank you.
Thank you, Dr. Karthikeyan, for that very exhaustive and wholesome presentation.
Thank you.
I would also request our audience to send in their questions quickly so that we can take a couple before the program ends. Meanwhile, just a quick question to you, Dr. Karthikeyan, to understand the process of this GAE, I think we also need to understand the knee osteoarthritis first, as it is a non-reversing condition you mentioned. So how does a patient actually identify those symptoms that, okay, I have got knee arthritis, osteoarthritis? Does it start from somewhere else, or is it a direct shooting pain in the knee? So what are the ways to identify that pain?
Okay, that's a very good question. So osteoarthritis starts off very slowly, as I said, gradually builds up on you. So early on, the earliest symptom they would have is they would notice is when they do a lot of exertion, they do a lot of walking around, or they've gone on a tour and they do a lot of walking, and they climb a lot of steps. Then they feel severe pain at the end of the day in the knee joint or a bit of swelling. That means they have some problem, because it's like exertion has caused severe pain. And this probably is the early stage of osteoarthritis happening. When as it progresses, they will know that some people will walk to the temple and come back and they start having pain. That's like a moderate activity and they have pain. So pain, swelling, or stiffness when you wake up in the morning, your joints feel very stiff to move around. These are the early symptoms, or rather symptoms of osteoarthritis, which should tell you that there is something wrong with the joint, because these are the indications that your body is giving you, tell that there is something happening in your joint which is not right. And yes, they should get evaluated by a doctor who will examine them and also do x-rays and other tests if needed to find out the problem. Yes.
So as you said, the GA is not recommended for people with rheumatoid arthritis. So what is the difference between these two arthritis, osteo and rheumatoid?
Okay. Osteoarthritis, as we talked about, is natural wear and tear over time with your joints. Just like as you get older, your skin gets wrinkled. That is changes in your skin. Just like that, changes happen in your knee joint as well. And that's when you get this problem of pain. And unfortunately, as I said, it's happening earlier, much earlier than in the 60s. People used to get it in the 60s. Now they're getting in their 50s and 40s. Rheumatoid arthritis can happen even in young age, because it's an autoimmune condition. What it means is your body's defense system is supposed to attack harmful cells which they enter your body, like bugs enter your body. They're supposed to fight them. But unfortunately, in these patients, your body's defense mechanism starts attacking your own body. They start attacking your joints. You get inflammation in the joint. And ultimately, inflammation is what causes the pain. So they will develop pain in the joints and swelling. And it may affect not just the knee joint, it may affect your joints in your hand and feet and everywhere else. It can be a very debilitating condition as well, because it causes severe pain and disability for the patient. Yeah.
As you also mentioned that osteoarthritis is very, very common. The incidence is very high, particularly in India. So in how many cases of GAE do you actually end up doing in a month?
In a month, we probably treat around 20 or 30 patients in a month, because we get a lot of patients who come to see our orthopedic doctors for having pain due to their pain. And a few of them will end up having knee replacement because their knee pain is very bad. And sometimes they get referred from other hospitals with complex problems, because we are a highly specialized center. We treat a lot of complex patients, even referred from other orthopedic hospitals. So we do around 10 or 20 patients a month. And this is even without the awareness program. This is only the doctors who see the patients. They know we do this procedure, so they refer the patients to us. The patient hears about it for the first time, because when you explain to them that this is a procedure we're doing, yes, of course, they feel a bit reluctant, because they say that I've not heard about this procedure before. What is this you're talking about? None of my doctors know about it. So this is without awareness. But I'm sure when the awareness increases, there will be a lot more influx of patients, because a lot of patients are out there who are suffering from pain who would benefit from this treatment.
I'll quickly take the questions now. The most obvious question, Bala Subramanian GV wants to know, what is the cost of the treatment and whether insurance coverage is available?
Yes, insurance does cover this procedure. Of course, it depends on your type of insurance cover you have and the company you have insurance with. But we've had patients we treated with insurance, and the procedure costs usually around 1.7 lakhs for the procedure, because we use very specialized catheters, very, very fine catheters. So the blood vessels are very tiny. We have to use specialized catheters to get inside them, and we use highly specialized angio equipment to even identify these blood vessels. So the procedure costs around 1.7 lakhs, and they stay in hospital for 2 to 3 days maximum. As I said, patients can be discharged the same day, but in our setting, in our setup in India, patients want to make sure they are completely okay before they get out of the hospital. So that's the reason we keep them in for. If they're young and they are very okay, we may discharge them even the same day. Yeah.
So Sashikala Sivaprakash wants to know that in GAE, what are you actually doing for the patient? You're reducing the inflammation, or you're only numbing the pain for a temporary period?
Yeah, we are reducing the inflammation by blocking the blood vessels. It's actually a vicious cycle. When they have inflammation, they have increased blood flow. And there's increased blood flow, more inflammation happens. So when we block the blood vessels which are causing the inflammation subsides, and that's when they get pain relief. In numbing medicines only work for a few hours. They don't work for this long. So this procedure they've done, and they've done studies in animal models and seen that doing this procedure subsides the inflammation in the joint, and that's why they get sustained pain relief.
And is GA available across different centers in the country, or it is still very limited procedure?
I would say it's very still limited. Only very few centers in India offer this procedure, and we at MIOT are proud because we are an orthopedic center, and we are happy that we're able to offer all round service for the patients with this procedure. Yeah.
Since it is really a non-invasive surgery, so do you also measure its success rate? Like, is there any success rate for GA?
Yes. Usually patients have 80 to 90% improvement in their pain symptoms compared to what we do a pain score. We have a questionnaire for them to do before the procedure to objectively identify what the pain score is. And we have a score for that. And after the procedure, we'll bring them back to the clinic in 2 weeks' time, in a month's time. Again, we do the same score and ask them to do the same by themselves. And we usually see that there's an 80 to 90% improvement in the pain. And pain reduction is the key in this procedure because we don't need to do an MRI scan to see whether the synovium has got thin, because ultimately what we're expecting to see for the patient is pain relief. Okay, and the sustained pain relief, yes.
Dr. Shalini Murli says, as you mentioned those tiny particles being inserted in those abnormal veins. So what happens to those particles after the procedure is over and after the catheter is removed?
Okay, these particles stay inside these blocked blood vessels permanently. Clot will form over them and they stay inside. But these are, as I mentioned, they are highly inert medical grade materials. So they are proven to be okay to stay inside the patient without causing much of any harm to the patient. So they do stay inside the patient. That's it. Yes.
Are there any disadvantages of GA?
There are no disadvantages to doing GA because I can't see of one, because patients having pain and this helps relieve the pain. So there is no disadvantage of doing a GA procedure. Yes. Of course, we have to find the right patient. If they have very mild pain, they may not get much benefit, or if they are suitable for knee replacement, then they should go for a knee replacement. Yes. So we do evaluate the patient, and not only for GA, but if we find that the patient is suitable for a knee replacement and ready for one, we will recommend to send him to the orthopedician to have it done.
And the fact that the impact of GA kind of lasts for 2 or 3 years. So during that period, the patient can go for the usual regular walks, and people follow all these 10,000 steps or brisk walks for reversing other conditions or kind of minimizing other conditions. So in that 2-3 periods when the pain is considerably reduced following GA, can the patient revert to their routine, normal life?
Absolutely. We usually tell the patients that the beginning to start doing things what they were doing just before the procedure, not overstretch them, because they can get overzealous. Suddenly the pain is gone. They start climbing a lot of steps and start doing this 10,000 steps. But that's like you have to gradually build up the exercise routine as well. Because if you're not doing very much before the procedure due to pain, your muscles are weak and your joint is weak, then we tell them that in the first few months, you do what you did before the procedure and you'll not have pain. After that, they can slowly increase the exercise to improve the strength and the endurance of the muscles. Yes, they can do activities to reduce their weight as well, which will, in the long term, slow the progression of the process as well, as I mentioned earlier.
Joseph Raja Pillai is asking if GAE procedure can be done for similar shoulder conditions.
Yes, absolutely. Now there is evidence for shoulder, like frozen shoulder or adhesive capsulitis, where they're not getting relief from the shoulder pain. There are procedures we are doing for this condition as well. Yes, for shoulder as well.
And a patient with Paget's disease of the bone. Are such patients also eligible for this GAE treatment?
Patches disease is actually a condition which affects the bone itself, not the joint. So actually, this treatment wouldn't work for this condition. This is actually treatment for the joint, not for the bone.
So likewise, another similar question is, people with cardio issues who have a stent in their heart, can they get this procedure done?
Absolutely, yes. A lot of our patients are elderly patients. Our patients who had coronary stents are bypass done and they're not fit for anesthesia and surgery, and they get this procedure done. We can do that, no issues.
There are a couple of specific questions, like Kishan Kumar is saying, my brother met with an accident 2 years back and had a surgery in his right knee.
Mm-hmm.
Ever since, following the surgery, he has swelling and complains of pain. So can GAE be now done for him?
Okay. This is, he had trauma to the knee and there is some damage to the knee. We need to do a careful evaluation to see whether it's now this degeneration in the joint which is causing the pain, or there is some still unresolved issues in the knee joint with regard to balance, which is causing the pain. We need to evaluate this properly first with an orthopedician before we can say that, yes, you'll be benefiting for a GAE, because 2 years is very early for osteoarthritis setting. Usually when the knee injury happens, it takes a bit of time. This is wear and tear, so it takes like a few years before they have osteoarthritis. So this guy needs to be evaluated first to see whether it's the pain from the damage which happened earlier, or is it osteoarthritis. If it's osteoarthritis, yes, we can offer treatment.
So Narmada T is asking you to once again repeat the age category who can undergo the surgery, because you also did mention that if a patient comes in his 40s, doctors try to delay the knee replacement surgery because that's shelf life is for 20 years. So what is the younger age limit and the upper age limit to do GA?
Okay, because it's a very minimally invasive procedure, just under local anesthesia, there's no major disturbance to your body function or body condition. There's no age limit for us to do GAE. If the patient has, the only criteria for us to do procedure is the patient has severe pain, be it young patient. As I said, the patient who did 2 days ago is only 45, and she has very bad pain in the knee due to their osteoarthritis. We can treat it. And patients up to the age of 90 years as well, if they are fit enough and they can lie on the table for 1 hour for the procedure, we can do the procedure, yes.
Again, there are questions like, does hyaluronic acid injection give any relief as advertised? And also, can a diabetic or a high BP patient undergo the procedure?
I will answer the second question first. Definitely patients with high BP, heart conditions, and diabetes, of course, can undergo the procedure, because as I said, this is just under local anesthesia. There's no, as the patient point of view, is just an injection in the groin. Of course, it goes quite deep into the blood vessels supplying the knee joint, but patient doesn't feel all these things. For them, they just come and lie on the X-ray table. They'll be awake. We'll just do an injection in the groin, which stings a bit and then goes numb. After that, they are lying on the table for 1 hour. We do all the manipulations of the catheters to make sure we can get there and do the treatment. And during the treatment, there is no discomfort or pain that happens. Okay, so diabetic, the advantage of interventional radiology as a whole is that even patients with comorbidities and even patients as old as 90 years, we can still treat them because we're doing it with minimal invasive procedure. The first question about hyaluronic acid, to put it this way, we are a very specialized orthopedic center. We see all varieties of cases, very complex cases. We do not recommend this hyaluronic acid because there is no proven evidence that it works. But people sometimes get desperate. I can understand, because their pain is very bad. They just want some treatment to help their pain. And when somebody advises that, yes, this can relieve your pain, I don't blame the patient. They would try that option, but we wouldn't recommend the treatment because it's not proven as such to help with the long-term pain relief.
Gunalini has had a hip surgery due to a car accident, whether she can undergo GAE for her knee.
Definitely, if she has osteoarthritis in her knee, if the X-ray shows that she has osteoarthritis and she has severe pain, yes, we can offer her this procedure.
Hemlata is asking, does the GAE procedure heal when the arthritis patient is suffering from the absence of natural tissue between their knees?
Yes, the natural tissue is lost. We can't recreate it or doesn't regenerate. This simply reduces the inflammation which happens secondary to this loss, because the cartilage loss which triggers all this inflammation to happen. We are blocking the second point, which is the inflammation. We're providing pain relief. As we said, there is no cure for this condition. The only way for her is to have a knee replacement, which will replace the artificial cartilage and everything like that there. But if she's not willing for a knee replacement or she wants to delay it for some time, we can do this procedure to reduce the inflammation and the pain. The natural tissue is lost, but we cannot regenerate it.
Monisha Ilamurugu is wondering whether any clot formation also takes place in this procedure, and is there a risk of any other complication?
Okay, that's a good point. There's no clot forming here. These particles we put inside will block the tiny blood vessels, which are we're talking about blood vessels smaller than a millimeter. So it blocks them. There's no blood clot forming there. And because the patient mobilizes within few hours of the procedure, normally blood clots can happen after surgery, as knee surgery and all, because they'll be in bed bound for a few days. And after a major surgery, there is a lot of inflammation that happens. So blood clots can form, she's right. But with this procedure, it's very minimally invasive. There's minimal disturbance to your normal body function and all these things. So no, there's no risk of clot. Complications wise, the complications we can talk are when you're releasing these particles, if the particles block the blood vessels going to another area, they can cause damage to that. But again, that's why we do this angiogram to make sure we are in the right place before we release these particles to block the blood vessels. Yes.
Right. How would a patient do a follow-up after the procedure of GA? Like once that 2 or 3 year period is over, will the pain again come back with the same intensity?
Yes, the pain can come back, as I said, because the underlying damage to the joint and the loss of cartilage is still very much there. So the pain can come back, and literature shows that after 2 to 3 years, the pain recurs. It may come back with the same intensity, but the advantage of GAE is that if the inflammation is again set in the joint, we can repeat the procedure. If the patient is still not willing to go for a knee replacement, we can offer the procedure to give her another 2-3 years of pain relief. There's no harm in repeating it. If there is inflammation, we can go and treat.
Jaya Vigneshwari is 60 years old and diabetic, who has removed, she says, I have removed my small finger due to injury and pus formation. Can I undergo GAE and get relief from my knee pain?
Definitely, yes. Yeah.
Similarly, somebody else's grandfather has Parkinson's and is on medication. Is GAE suitable or advisable?
Yes, we can still do, as long as the patient can lie flat for 45 minutes to 1 hour, because I don't know the degree of Parkinson he has. Some people have a lot of tremors or cannot lie down flat. If that is the case, we have to evaluate them and see them. If we can give them some medicine to relax them to make them lie flat, because they can be very stiff. I don't know the degree of Parkinson's he has, but as long as he can lie on the table for 45 minutes to an hour, we can do the procedure. There is no interaction with the medicines he takes for the Parkinson's with this procedure.
And if a patient is having blisters, can GAE be performed?
Is it the question that to treat the blisters, asking for GAE or?
No, just says if a patient is having blisters, after modalities can be performed GAE. Right. Two people are asking the same. Okay, I think we could just forget this. There was one very, very long question. I think I'll wind up with that. Somebody wanted opinion on his wife who has been taking Hyalast S20 mg per ml sterile viscoelastic sodium gel for intra-articular injection for both the knees once a year for the last 2 years. Yes. The same is due this year in about a month's time, and she has been advised of this injection to overcome the stiffness in the joints while walking. And there is a lot of discomfort she has in her joints. She has not developed any erosion in the knee bone joints as per the x-rays. She's feeling comfortable now, but he wants to know if this GAE that you have explained so beautifully is suitable in his wife's case, because they're exploring if they could avoid the yearly once injections.
My immediate answer would be yes, but we need to see her in the clinic, evaluate her, do x-rays and things to make sure that it's osteoarthritis, and we need to know the nature of the pain as well. And if we can know that, and if he thinks the inflammation is there, yes, we can do GAE to provide a sustained relief instead of having this yearly injection. Yeah.
Right. Thank you. I think we have already overshot our time, and there are lots of still remaining questions, so which you could, Dr. Karthikeyan, perhaps answer them individually. And many are repetitive. Everybody's asking again and again about the cost, about the insurance coverage, and also they have some specific comorbidities in that case where the GA is advisable.
Yeah, again, as we repeat, the cost is around 1.7 lakhs for the procedure itself, and they expect to stay for 2-3 days. So That's the cost of the procedure. But having said that, we are running this camp for genicular artery embolization, dedicated camp for osteoarthritis knee patients from July 1st to 6th. At this camp, they can get a consultation and the x-rays done and the evaluation done for a discounted cost. And the hospital is planning to give a discount for the procedure itself when they come for the procedure for patients coming through the camp. This is just to create awareness and provide benefit to the patients who are interested in having this treatment. So that's what I want to tell you.
Thank you so much, Dr. Karthikeyan, for sparing your time for such an informative and so useful session. And as you were saying, backroom, that pain is perhaps sometimes good for the body because it indicates that you have a problem.
Yes.
And when we have pain-free solutions available to treat that problem, then it also helps to be aware of what we can do and choose not to do.
Absolutely.
On behalf of the Hindu, I thank you all who could attend today's webinar on genicular artery embolization presented by the MIOT International under the Hindu Wellness Series. So till we assemble for our next webinar, wishing everybody happy walking and good health. Thank you.
Thank you, Mrs. Basu. Thanks for moderating this session. Thank you.
Thank you.